Thanks so much, guys, for all of you guys, all of the learners who are joining us again. This is talk number 5 out of a 5-part series, and thanks to the folks that are joining for this lecture in particular. So also wanted to really say a heartfelt thanks to Joanne and Taryn for submitting cases that we'll get to discuss at the end of this talk. Please hold on to my contact information and just really feel free to reach out at any time, even after the series is completed, to discuss any cases that you may come across in the future. So today we're going to be focusing on recognizing special considerations for certain populations of people with hepatitis B infection or who are at risk for hepatitis B infection. So let's talk a little bit more about this. We'll come back to this a little bit later, but this is our 28-year-old pregnant woman now. So this is the case that we've kind of developed every week by week. So 28-year-old pregnant woman, she's 32 weeks, in gestational age, who was born in the United States. Her parents, as you will recall, emigrated from Taiwan 2 years before she was born here. She was screened for Hep B. She came out positive as her surface antigen to hepatitis B and core antibody were both positive. You get some additional serologies, including making sure she doesn't have acute Hep B, her IgM core antibodies negative, she is E antigen positive, and her Hep B DNA viral load count is very high. It's 1.1 million IUs. Her ALT is normal 18. So now what? So kind of tweaked this case to talk about it in the context of what we're going to be covering today. So keep this in mind, and I think we're going to come back to this towards the end as a point of discussion. All right, so we know that during pregnancy, the immune system is modified to tolerate the fetus and to prevent quote unquote fetal rejection, because your body's always trying to sense things that are not its own. And so immune priming is thought to occur via macrophage activation by both CD4 and CD8 T cells. And CXCL3 expression in liver macrophages is ineffective at birth and becomes competent as one becomes older. And this is important because of the risk of mother-to-child transmission, and also because the age at which you acquire this infection, as we've discussed in prior talks, really influences your risk to go on to develop chronic infection. And so at birth, as newborns, babies do not have this good clearing immune system to really be able to handle the virus if they get it transmitted at the time of birth. And that's why so many of them go on to develop chronic infection if they get infected as a newborn. And again, this could be the potential mechanism for the inverse relation observed with age-dependent clearance. So the younger you are at which you are infected, the higher the risk of not clearing it and developing chronic infection. So worldwide, mother-to-child transmission actually accounts for 50% of chronic infection, and vertical transmission can happen via germ cells, transplacental or intrauterine, and then perinatal at the time of delivery. Again, most transmission is going to happen at the time of delivery, but you can get it, and it can occur prior in the gestational kind of phase and after delivery. And this is most commonly seen in the context of failure of immunoprophylaxis and in the postnatal period. And we're going to talk about what immunoprophylaxis means. So how do we manage pregnant women? The most important thing is to start by screening all pregnant women. So it's recommended by the OB societies, the liver societies, the federal agencies, including U.S. Preventative Services Task Force and CDC, to screen all women with a minimum for Hep B surface antigen as early as possible in pregnancy. So it should be one of those tests that we are offering to all pregnant women the very first time we see them. And in anybody who tests surface antigen positive, it's important to assess liver function and liver fibrosis as early as possible using some combination of labs, imaging with an ultrasound, and other non-invasive markers to try to determine whether or not, the most important thing you're trying to determine here is, do you have somebody with cirrhosis who's compensated versus somebody without cirrhosis? And then, and that's because the risks to the mom are greater if you do have cirrhosis. You want to check at a minimum your serum ALT level, your e antigen test, your Hep B DNA, and these tests should be checked close to the third trimester in order for you to make a determination about whether or not this person should be recommended for antiviral therapy to be initiated in the third trimester to try to reduce the risk of mother-to-child transmission. And it is recommended that we do close monitoring of the ALT and the Hep B DNA throughout third trimester and up to 6 months actually postpartum. And that's because of the risk of flares postpartum. So the risk of, we're going to refer to mother-to-child transmission as MTCT for the remainder of the talk. So the risk of mother-to-child transmission with prenatal procedures is unclear. Some of the earlier studies kind of overstated the risk of amniocentesis and other procedures that are invasive. So this can be as high as 50% risk in mothers, but it's really in mothers who have very high DNA viral load levels. And invasive procedures, it's still recommended, should be performed when medically indicated. And so we don't actually modify recommendations around recommending amniocentesis, chorionic villus sampling, and other things. The only thing to counsel women about, particularly those who have very high DNA levels, they should be informed of the potential increased risk of Hep B transmission in part of that shared decision making. The data on benefit of C-section versus vaginal delivery are very conflicting. So we actually don't recommend a mode of delivery in a woman who's Hep B infected. So that shouldn't really be an influencing factor, and it rather should be guided by obstetric indications for C-section. We do know that DNA from this virus is found in pretty high levels in vaginal secretions, up to over 50% of cases. So you can get mother-to-child transmission through both modes, and it's not clear if C-section increases your risk of mother-to-child transmission. So what can we do to really try to reduce the risk of transmitting this virus between mom and baby, which is most commonly done at the time of delivery or birth? There's two things. One is we can administer hepatitis B immunoglobulin, and the second thing is we can administer a hepatitis B vaccine, and these both should be given within 12 hours after birth. So it's not prior to discharge from the hospital after delivery, but within 12 hours is the optimal timing to reduce and get the maximal benefit of immunoprophylaxis. And this can reduce the risk of mother-to-child transmission by 85 to 95%. And the risk of mother-to-child transmission is largely influenced by the presence of e antigen. So in mothers who are e antigen positive, and remember, younger persons who have this infection, remember we talked about the phases of this infection, are more likely to be in that earlier stage of infection, right, of being e antigen positive. So you're going to see in mothers who have this virus, more of them are going to be e antigen positive typically. And again, in that earlier phase, especially the earliest phase, what we used to call that immune tolerant phase, the Hep B DNA level is also very elevated. And we're going to talk about how that DNA level influences your risk of transmitting this. So in e antigen positive Hep B infected moms without any vaccine, for hepatitis B, we know that there's a 90% or greater risk of the infant getting chronic Hep B infection. In women of childbearing age who are e antigen negative, it's a much lower risk of transmitting this virus and developing chronic Hep B in the infant. As I mentioned, the optimal immunoprophylaxis We can give a baby at birth within 12 hours is both a combination of Hep B vaccine as well as administering immunoglobulin. And this will reduce your risk substantially in E antigen positive moms from greater than 90% to 10 to 15%. So that's a pretty substantial reduction. And even in E antigen negative moms, the risk, even though it's small, in terms of the risk of mother to child transmission and the baby going on to develop chronic infection, it goes to less than 1%. So really, this is really compelling data that should really influence us to highly recommend, and as a public health practice, really administer Hep B vaccine and immunoglobulin to moms who are delivering, women who are delivering babies at the time of birth. It's important if you start the Hep B vaccines in the hospital that the clock kind of starts then in terms of when you should be bringing the infant back for doses at 1 month and 6 months to get that lifelong immunity, okay? Now, who should we be recommending for antiviral treatment at that last third trimester of pregnancy? Well, we know that the level of Hep B DNA influences your risk of perinatal transmission. So we know that moms who have DNA levels greater than 8 log copies per ml is associated with the highest rates of perinatal transmission, between 9 to 14% or 15%. Transmission rates, even with DNA levels that are lower than that, in the 6 to 8 log copies per ml range, are still elevated at 3.2 to 6.7%. And remember, 1 IU translates to 5.3 copies. You can do the conversion there. So the thresholds are even lower if you're talking about IUs per ml. Now, the agents in terms of antiviral therapy that are considered top line or first line include lamivudine, talbubidine, and tenofovir. TAF is actually not considered safe during pregnancy, and that's really because of the absence or lack of data, safety data with TAF. So I think once that data is accumulated, we might see a change in some of these recommendations in the future. Tenofovir is preferred to minimize the risk of emergence of viral resistance during treatment. So as you will recall, lamivudine and talbubidine have higher rates of resistance, which we covered in last week's talk. And so therefore, the AASLD, American Association for Study of Liver Diseases, and other societies recommends tenofovir as the preferred antiviral agent in the third trimester. Now, tenofovir, again, is preferred in mothers, particularly if your Hep B DNA is greater than 200,000 IUs per ml. It's effective even if resistance to lamivudine and talbubidine has existed at some point in the past. So those are really for women who have met indications for treatment previously, who may have been treated with lamivudine and talbubidine. Fetal exposure to drugs in the first trimester can theoretically cause mitochondrial toxicity and potential risk for fetal organogenesis. And so the ideal timing is really felt to be between gestational weeks 30 to 32. Some societies go as low as 28, but 30 to 32 is what we will recommend. And mothers with cirrhosis should initiate antiviral therapy as early as possible, so independent of the week of gestation, to avoid flares in their hepatitis B, which may cause them to decompensate and lead to poor maternal and fetal outcomes. So if you have cirrhosis, forget about the gestational week. If you have a pregnant woman with cirrhosis, with Hep B, you should be initiating antiviral therapy as soon as early as possible. Now, what happens postpartum? Postpartum, you have a lot of hormone-driven changes, and these hormone changes actually can drive a lot of immunological changes, and these can result in actually flares in hepatitis B. Breastfeeding does not increase your risk of hepatitis B transmission. So this postpartum period needs to be monitored from the woman's standpoint to see if she's developing any flares in Hep B. Mothers on treatment can choose not to breastfeed, as medication can be secreted in small doses in the milk. Although breastfeeding itself is not considered a contraindication in a woman who is infected with Hep B, and does not increase your risk of Hep B transmission to the infant. The only exceptions to any of this is if there's severe mastitis or obviously blood in breast milk at the time of breastfeeding, or milk expression. And in those cases, we typically will say to hold off on breastfeeding until the mastitis heals itself or there's no more obvious blood in milk. Hep B infected pregnant women who are not on antiviral therapy, as well as those who stop antiviral treatment at or immediately after delivery, should be monitored closely for up to 6 months after delivery because of this hormone-driven immunological changes that can result in Hep B flares. And we'll talk about how often to bring them back and check and what labs to check. And then long-term follow-up for all of these moms should be continued to assess needs for future therapy. So don't forget about your pregnant women after you monitor them for 6 months postpartum. It's really important to monitor them long-term because they have chronic Hep B infection. So these are kind of really nice infographics, algorithms, if you will, developed by the CDC and available at the website that you'll see below. And this is part of their perinatal hepatitis B prevention program, for which they've been able to actually fund a lot of coordination services nationally. Now, so this really hinges on knowing the surface antigen test. So when that test is available, and not always do we have this test available. Sometimes women present very late in terms of engaging in care. Sometimes the first time you're meeting a woman is when she's coming in for delivery and you don't have the benefit of knowing their surface antigen status. But in those that you do know the test because it's been tested before delivery, if you know that they're positive, it's important for that to be a part of the woman's labor and delivery chart. So the electronic health record, the infant's hospital record so that they can be appropriately immunoprophylaxed. Your pediatricians and the nursery kind of staff on the provider end need to be in the know that the infant will need hepatitis B vaccine and immunoglobulin within 12 hours of birth. Both of these things are administered in separate limbs within 12 hours. And the public health department collects this data and follows actually what happens to the infants down the road. And so public health notification is important. And then reporting the results in immunization registries is also part of this. In women who are negative, it's important to still reassess Hep B risk factors at the time of delivery, such as, a known partner with Hep B infection, unprotected sexual intercourse certainly can increase with a new partner, if they're not in a monogamous relationship in which we know the partner status. Anything that may trigger a risk factor, again, greater than or equal to 2 sex partners in the previous 6 months, an STI, infection with a drug user, partner with injection drug use, or the patient themselves with injection drug use, any clinical picture of hepatitis should trigger retesting for surface antigen. And then again, based on the mom's surface antigen result, you go down this pathway. This is a nice thing to kind of refer back to. And then based on the baby's weight, you will recommend vaccination, scheduling for the vaccine. And then again, we've been lucky in the United States to have CDC funding around a perinatal hepatitis B coordination program that's actually funded a lot of additional support to follow up on women and infants born to moms who have Hep B infection. All right, what if you don't know the surface antigen test result at the time when the mom comes in for delivery? So what you want to do is, if the mom's surface antigen status is not known, definitely send the surface antigen, but you may not have it back in time, but by the time the mom is delivering. And so based on the baby's weight, if they weigh less than 2,000 grams, you want to go ahead and administer the first dose of vaccine and immunoglobulin within 12 hours. You must treat them as if they are positive. If the baby's weight is less than 2,000 grams, you want to administer the first dose of vaccine within 12 hours of birth. Hopefully then once the mom's results are available, if they're surface antigen positive, it'll take you down the pathway of administering another dose of vaccine 1 month after birth, which would be standard, and then alert the pediatric provider If they're negative, you just follow the recommended vaccine schedule and then place a copy of all of the documentation, what you've done to mom and baby in the record so that they can be followed by the appropriate teams. And then in women who the babies you don't give the immunoglobulin to and the mom it turns out to be positive, you still want to go ahead and administer the Hep B immunoglobulin no later than 7 days after birth, and record this in the record and refer the woman to the CDC-funded perinatal hepatitis B coordination program. All right, and I think there's a question that's come up. Okay, it was just, I think, a hello, but maybe there may be more question to follow. So just feel free to type it in and then we can come back to it. So this is another way to look at everything in terms of an algorithm. That's a great question, Kawika, Lou, about how does one deal with vaccine hesitancy refusal among patients? So let's save that question towards the end. I think that might make for a nice discussion. Would be curious to hear about how we can learn from one another on that. So surface antigen positive moms, you want to still assess their Hep B stage and disease activity. This is again for women who are pregnant, so this in pregnancy. If they have advanced fibrosis, which we consider stage 3 or 4 out of 4 fibrosis, or the ALT is greater than 2 times the upper limit of normal, you may still consider them for, find out whether or not they're taking any antiviral therapy. If not, you want to be really guided by whether or not their Hep B DNA viral load is detected. If they are detectable and if they are on another Hep B agent, you typically want to talk about switching them. And then if the Hep B is not detectable and they have Hep B and they're on a prior agent, in those patients you can continue their current agent actually through the end of pregnancy. And if not, you would be switching them if their Hep B DNA is detected. Here they're advocating to do the testing at 26 to 28 weeks, largely because you want to get the results back in time, and depending on the labs, you may not be getting the results back until 28 weeks plus. So it may take a couple weeks depending on where you're getting the test run. If the Hep B DNA is greater than 200,000 IUs, you wanted to think about initiating tenofovir in that at least 30 to 32 week range. And then it's recommended that you discontinue antivirals at delivery or within 1 month postpartum. And that's because of the lack of benefit for extending treatment in preventing flares of Hep B in the moms. And you want to monitor, and this is the key point, the ALT every 3 months for the first 6 months. So at 3 months, and then at delivery 3 months, and then 6 months, or after stopping the antivirals. Typically, you can just, depending on the setting in which you're practicing, at a minimum an ALT, oftentimes providers will also be checking DNA levels on the schedule. Remember, the DNA, you might see a rise in the DNA level before you see a rise in the ALT level. How much of that is of clinical significance can be debated. And so therefore, following just the ALT would be okay as well. Although I think we're very data driven these days. And so knowing if the DNA is becoming undetectable to detectable is a helpful thing, because you might monitor them actually a little bit more closely. Again, breastfeeding is not contraindicated on antiviral therapy. And so for those moms who do want to continue for up to 1 month postpartum, it's not contraindicated. Okay, so that's kind of, and I think Kawika, we're going to get back to your question about vaccine hesitancy refusal towards the end. I think that's a good thing for us to discuss. So moving from women who are of childbearing age and those that are pregnant, and screening them for Hep B and what to do if they are Hep B surface antigen positive, I think the other population we wanted to spend a little bit of time talking about was this concept of reactivation. So reactivation of hepatitis B is defined as the clinical syndrome characterized by a sudden increase in Hep B replication due to a loss in immune control. We're actually seeing more and more patients who are at risk for reactivation because of the more widespread use of a lot of immune suppressive, immune modulatory, or cytotoxic therapies for a variety of conditions now, from rheumatological to GI to oncologic. and even dermatologic and other immune-mediated conditions. So we're seeing a lot more immune related medications used in clinical practice for a wider variety of immune-mediated diseases. The important things to remember is that this Hep B reactivation can happen certainly in patients who are surface antigen and core antibody positive, but it can also happen in surface antigen negative and core antibody positive. And this is independent of whatever the surface antibody test is showing. So if the surface antibody test is positive and your core antibody is positive, you're at risk for reactivation. If the surface antibody is negative and your core antibody positive, you're still at risk for reactivation. So you can just have the core antibody without the surface antigen and still be at risk for reactivation. I think a lot of providers don't realize that. So, and the only way we're going to know is that if you have somebody you're starting immunosuppressive, cytotoxic, or immune modulatory therapy on, it's important to not just check the surface antigen and the surface antibody, but you need to know the core antibody status. And we certainly every day see a wide clinical spectrum of patients presenting with reactivation. This can range from really silent asymptomatic reactivation that we're only noticing on liver tests because we're monitoring, versus to complete overt liver failure. You know, you're sending them to a transplant center to see if they would at all be considered a candidate for liver transplant because they're in acute liver failure from Hep B reactivation. It primarily occurs with immunosuppressive drugs. One of the challenges in the literature when you're looking at this area is that there's a lack of standardized criteria around how we define reactivation. So I think we're going to see more work around guideline development and agreement across between national organizations that are starting to define this. But this makes it somewhat difficult to compare one study across the other because different definitions are used. So the AASLD, which is the American Association for the Study of Liver Diseases, it's our national liver organization, do have established criteria. They say arise from Hep B DNA from baseline with or without the reverse seroconversion. So somebody who goes from surface antigen negative to surface antigen positive. For somebody who's just in a core antibody positive patient, or also you can see this after Hep B reactivation, a flare with the ALT can occur. Other less, and you can see how that criteria, you know, is a little bit loose. It's just any rise in your Hep B DNA from baseline. So other societies or other papers where this has been described have used more stringent, you know, greater than or equal to 1 or 2 log increases in your Hep B DNA. You can use a Hep B DNA cutoff if the ALT suddenly increases. You go from basically an undetectable Hep B DNA viral load to a detectable one or presence of having an E antigen. And then ALT cutoffs, you know, greater than or equal to. So you can see even between kind of what's been laid out in a lot of the literature papers and their methods versus even this criteria, which isn't give us very strict, you know, what does your ALT level need to be, your Hep B DNA level need to be, that there's still some room for improvement here. But there's some work being done at least to try to standardize some of the criteria. All right, so what puts somebody at higher risk for reactivation? Men have higher risk, younger persons have higher risk. Having an elevated ALT at baseline before immunosuppression puts you at higher risk. And then having underlying other comorbidities, you know, like heart disease, kidney disease, other things can put you at higher risk. There are some viral factors. Having a high Hep B DNA level puts you at higher risk. Surface antigen positive patients are at higher risk than those surface antigen negative patients who are core antibody positive. If you're E antigen positive, that also puts you at higher risk. And then the other category we generally think about are the drugs. And so the intensity and duration of immunosuppression influences risk. Rituximab is in like the highest, you know, category along with stem cell transplant recipients. In terms of highest risk for reactivation. And we're going to talk a little bit about that level of risk here. So this shows you increasing risk based on kind of category of immunosuppressive agents or, you know, transplant recipient outcomes. So If you are a recipient of a stem cell and or a solid organ transplant, you have a very high risk of immune reactivation of Hep B. And so typically all of these patients are prophylaxed. If you are receiving an organ from a core antibody positive donor, certainly you will get lifelong prophylaxis for hepatitis B. This is like something we do for liver transplant recipients. So just because you're getting a donor that is core antibody positive doesn't mean that they actually have any real liver disease. They get screened for their DNA level at the time of procurement of their organ. But anybody who's core antibody positive, without surface antigen being positive, so they don't have chronic really infection, can be considered a potential donor. And then the recipient just gets prophylaxed for life because of the risk of Hep B reactivation. The other biggest, highest risk category of agents are B-cell depleting agents, and rituximab here is the agent that we see the most administered. But anybody getting a rituximab-based therapy for whatever immunosuppressive condition has a very high risk of Hep B reactivation. So it's really important that these patients get prophylaxed, and I'll talk a little bit about how not only they get prophylaxed, but they get prophylaxed for longer. And then even high dose steroids, people who are getting local regional therapy for liver cancer, TNF alpha inhibitors, which we see a lot of for dermatological, rheumatological, and GI immune mediated conditions. Every year there are studies published and presented at our national liver meeting about risk of reactivation with these TNF alpha inhibitors. And so a lot of work has been done to try to raise awareness amongst rheumatology providers, gastroenterologists, to be screening for Hep B to prevent, reactivation. Certainly systemic chemotherapy that's even not B-cell, does not involve B-cell depleting agents, and then other lower risk agents like methotrexate, which don't seem to really increase your risk of reactivation that much. So who should we be screening for Hep B? Anybody who is really any candidate for immunosuppressive, cytotoxic, or immunomodulatory therapy should be tested for Hep B surface antigen and core antibody before starting immunosuppressive therapy. The presence of Hep B surface antibody does not prevent Hep B reactivation. Hep B reactivation from anti-cancer therapies seems the highest amongst those who are surface antigen positive and core antibody positive, but again, can still happen in those surface antigen negative patients who are core antibody positive. And then reactivation from rheumatic therapies, which have much lower, these are the TNF alpha inhibitor agents, get higher in surface antigen positive patients, but still seen in those who are just core antibody positive. And what we do know is that Hep B testing rates or screening rates are very low, including those patients who are receiving with cancer diagnosis who are receiving therapies. So we should initiate Hep B prophylaxis for all surface antigen and core antibody positive patients who are receiving immunosuppressive or cytotoxic therapies. You want to administer it before or at the latest simultaneous to immunosuppressive therapy. So we never tell the providers they have to delay therapy if they're, we're getting a consult on the inpatient service about somebody's Hep B, surface antigen, and core antibody being positive. We'll go ahead and start antiviral therapy. And you continue Hep B prophylaxis antiviral therapy for the duration of immunosuppressive therapy and for greater than or equal to 6 months. And in those receiving those B-cell depleting agents, 12 months or longer after completing therapy. So throughout the duration of immunosuppressive therapy, standard is 6 months. Anybody getting anti-CD20 or B-cell depleting agent will get it for at least a year or longer. And the recommended prophylaxis agents are entecavir, tenofovir, alafenamide, higher potency, higher resistance barrier. In those patients who are surface antigen negative but core antibody positive, you can carefully monitor those patients with ALT, Hep B DNA, and Hep B surface antigen with the intent for if any of those things go up or become positive, then you initiate therapy or on-demand therapy. Some people don't want to worry about this monitoring and may talk to their patients about antiviral therapy, but it's not really indicated in somebody who's surface antigen negative if they can participate in this kind of careful monitoring plan. The one exception to this is anybody getting an anti-CD20 antibody or B-cell depleting agent or rituximab-based therapy. All of those patients, including those undergoing stem cell transplant, should be they can be monitored off prophylaxis, but the DNA levels need to be checked every 1 to 3 months. And patients should be monitored for up to 12 months after cessation. I actually just had a patient last year who got transferred to our hospital while I was on the inpatient service, who was an Asian guy who was core antibody positive and received prophylaxis for the duration of suppressive therapy and stopped 3 months after, and he was now 9 months after rituximab-based therapy and had fulminant hepatic failure from reactivation of Hep B. So it's something that we see. It's really important to follow these guidelines to prophylax patients on Rituxim, particularly based therapies, for much longer. All right, so moving from reactivation and pregnant women with Hep B infection, I wanted to spend a couple of slides, and I think this was a request even earlier in the series, Rachel, for us to cover Delta infection. So we had added this in a prior series. So Delta infection is a defective RNA virus that requires Hep B virus to be present in order to replicate. The incubation period is 5 to 64 days. You have two patterns of infection. One is superinfection, where you have already chronic Hep B infection and then you acquire acute Delta infection. This actually has a worse prognosis because more than 80% will go on to develop chronic infection and a more severe disease. So people will develop actually fibrosis in a much shorter period of time. There's also co-infection, where you're acutely infection with both hepatitis B virus and Delta virus infection at the same time. It's typically self-limiting because, again, your body as an adult, if you're acquiring both of these viruses, you get the B virus and your body, for most people, 85% of them, you'll go ahead and kick it out of your immune system. And when you kick Hep B out of your system, the Delta virus also cannot really survive and replicate. And so you end up clearing both viruses. But the typical pattern, while it's self-limiting, you can have this biphasic ALT where you have somebody who presents with like a viral prodrome, you check their liver test, the ALT is very elevated, and then the patient, you're monitoring them, you do the Hep B workup, that's positive, and then the liver tests come down, and then within 6 months, they still go back up, usually within the first 3 months. And it's you can get this biphasic distribution because you have both viruses there, but less than 5% go on to develop chronic infection. The risk factors who you're going to see this the most in today are injection drug users and persons with unprotected sexual intercourse. And you want to check an IgM and an RNA test. We talked a little bit about how you can get these tests done. I think somebody in the Baltimore area was talking about shared a case with us. We talked about resources through the CDC and the local Department of Health to check for. You can also ask them, if you do a liver biopsy, your pathologist to stain for Delta virus. The clinical presentation for most patients is self-limiting. More severe cases, you can have chronic hepatitis or fulminant hepatic failure. And the only treatment that's approved is actually pegylated interferon alpha, and that's administered for 12 to 18 months. All right, so I think from here, what we can do is, let's go back to the first case at the beginning, and then let's come back to Kawikalu's question, and then we'll go to the cases. So let's go back to, I think it'll require the least amount of switching around of slides too, if we do it this way. So we have this, our 28-year-old pregnant woman. She's 32 weeks gestation. She was born here. We know her parents were at risk for Hep B. We do her screening. She actually has Hep B. She's pregnant. You've ruled out acute Hep B. She's e antigen positive, and her Hep B DNA is high. So what things are you thinking about for her? What would you want to do next? And what information would you like to have? So we could take people off mute here. I think, Rachel, you're on mute right now.
Yep.
But if folks want to chime in, what do you think about this case?
Yeah, feel free to unmute yourself and let us know what you think, or you can put it in the chat as well.
So what factors influence the risk of mother-to-child transmission here in this case? The patient's, so Dylanora, thank you. The patient's viral load is high, yes. So it meets that greater than 8 logs copies per ml. So the DNA is very high. Thank you, Lydia. Is there anything else that increases the risk of transmission risk?
Hello?
Hi.
Yeah, the patient parents emigrated from Taiwan to United States of America.
Yeah, so that increases her risk of having Hep B, right? Because, and this was, again, if I had to guess, it was most likely mother to child or early childhood transmission for her herself, right? Because you've screened her, she's surface antigen positive. So Inyanga, you said the Hep B surface antigen is positive. Yep, so surface antigen being positive helps us it's the screening test we would offer any pregnant woman. And we know it's positive, so she's got chronic Hep B, right? So now if we look at, in addition to the viral load being very high, what's her risk of transmitting this virus to her baby? What's the other thing so the E antigen, Dylanora, yeah, the E antigen is being positive, and that's a risk factor, as I pointed out here. The E antigen status is very important because you have even a higher risk without particularly immunoprophylaxis for mom to pass this to baby and the baby to go on to develop chronic infection. That's really important. And with immunoprophylaxis, we know that we can reduce that risk. And this risk, even though with reduction, is still 10 to 15%, which is pretty high. If you're a provider counseling, a pregnant mom, that your baby has a 1 out of 10 or more chance of developing chronic Hep B infection with this, it's really important to know that it doesn't eliminate your risk of mother-to-child transmission, but certainly drops it or reduces it quite substantially. Okay, so from there, I wanted to talk a little bit about, so how does one deal with vaccine hesitancy? So this is in that postpartum period that you have a mom who's got Hep B infection. You're recommending immunoprophylaxis to the mom for the infant or the newborn. People want to chime in about what maybe their real experiences has been.
I think it's this is Kavika. So I've seen it on both sides. As a pediatric hospitalist, from the adult side, from internal medicine, it's really difficult. I mean, there's some communities where moms are refusing vitamin K, and I think part of it is education.
Yeah.
But and hopefully there will be some impact as far as education that goes along with the new changes in California for the improved scrutiny of medical exemptions. But it's just really, really tough. I mean, I remember speaking to moms and saying, or moms and dads and saying, look, I can't even do a CERC. You won't get the vitamin K. I mean, they're definitely like they won't let me put on the topical erythromycin. Again, some of these people are requesting opioids for their pain, and which is sort of a different issue, obviously. But I'm not really sure what the ideal thing, other than continuing engagement, saying that particularly with if it was a mom like that with from Taiwan with a high endemic risk, with obvious markers. I mean, I don't know at what point do we say, look, if you're not gonna, when we're not talking about just someone with the standard Hep B, but someone with obviously infection, CPS.
Sorry, CPS?
Yeah. Oh, Child Protective Services. So, I mean, it's sort of the last resort, because obviously it really fractures the therapeutic relationship. But, certainly, I mean, I can't do anything, obviously, if someone is if I'm attending a birth and, the mom refuses everything. and has a negative status and, doesn't seem to be infected. But if someone clearly has an infection, given the rather narrow time window, then it's kind of like that discussion has to go in the direction like, look, you are endangering the health of your baby by refusing to do this. I have a duty to report.
So I think what you're sharing really speaks to a lot of the real life challenges that we have. I've even had some patients where, I'll be counseling them about mother to child transmission risk. And this is usually before the time of delivery, somebody that I'm following. And they'll even have like they will have already had one child who actually acquired Hep B from mother to child transmission. So I've seen both cases. One where like the first infant got away and they were being managed somewhere else. They refused antiviral therapy. They may or may not refuse immunoprophylaxis at the time of birth. And they get lucky and the first baby actually doesn't get Hep B. And that kind of influences their decision to just take the risk. I've also seen in the women who meet, the recommendations for antiviral therapy because their DNA level is very high, they're e antigen positive, which again, most women of childbearing age are going to fall into this category, and say that they don't want antiviral therapy because of the risk of the medications and side effects and just not wanting to put anything of potential harm in their body that could potentially harm the baby. And then accept immunoprophylaxis at the time of birth or not accept immunoprophylaxis at the time of birth. So I think the only tools we really have at this point are to try to really engage to the best of our ability our patient populations around why this is important. This is an opportunity. Sometimes showing these numbers is helpful, or relaying these numbers, and that with these medicines we have the chance to not have them go through what we have to put the moms through lifelong, which is, following them lifelong and seeing whether or not they, screening them for liver cancer at a certain age. So really trying to effectively model that conversation. It's never perfect. There's always, I think, challenging, tough parts. So I think, Lydia, I don't think the moms have a choice. We need to educate them. Yes, they're putting the baby, the public health, and themselves at risk. Yeah, I think these are all really good points. And, our Department of Healths really do as good of a job as, they can based on the funding that they have dedicated towards these issues to try to help us follow up. And, one thing I do know is that based on the new CDC viral hepatitis director, funding is actually going to remain the same for this coming year compared to last year. So there is some talk about potentially having to cut back on the perinatal hepatitis B coordination program, which I think a lot of advocates have really voiced concern about because they do really help coordinate the long-term follow-up of making sure the infants get all 3 doses of the vaccine, the moms get plugged into care. And it is a real missed public health opportunity because we have such a highly effective vaccine that really our only, our really best chances for eliminating this virus, which there's a lot of talk of globally and nationally, is to really leverage the tools that we have in our toolbox to try to eliminate mother-to-child transmission because we know that there's such a high rate of developing chronic infection when babies get this at birth. So yes, I think I agree with a lot of what's been said here. Yeah, we're doing a really good job to try to educate them. And sometimes, I've actually engaged community leaders, people that they trust, these patients in the discussion, if they're willing to have those people involved in the discussion, depending on the communities that your patients might come from and your familiarity with kind of stakeholders or gatekeepers in the community. But remains a challenge. And I don't think we have an easy, one size fits all kind of way to have this conversation and convince people to accept. Yeah. All right. So I think from here, Rachel, we have a couple minutes. So I did want to move to Joanna's case. So I'm going to stop sharing for a second and pull that up. And Joanne, if you want to take us through the case while I pull it up, that would be great.
Okay.
Let me pull it up.
This is a 19-year-old prima gravida. She was born in Chuuk, Micronesia. And let's see what you got there.
Can you see my screen?
Yeah.
Okay.
Ponni, can you make it full? Yeah, just a
Yeah,
little
let me
bit
make it a
bigger.
little bigger.
Maybe.
That better?
Perfect. Yep.
Okay.
And we have some information from Chuuk. We had a vaccination record that indicated that she was vaccinated 3 times. Looks like the day after vaccination, she received her first. I don't know if that was within 12 hours. No record on that about whether she received HBV initially or not. But she came to me and we in Hawaii, we check everybody in pregnancy for surface antigen. So she came in with a unknown diagnosis until the pregnancy, and was very surprised. So that was in June at her initial visit. We did that, and no information on the partner. Not only no information on the partner, but she didn't want the partner was uninformed of the pregnancy, and she didn't want, she wasn't keeping any contact with him, and there was no way for us to be in contact with him. She lives with a auntie. I'm not sure if that's a blood relative or not. I don't have any information on her mother, her birth mother, or father, or family history that indicated any kind of hepatitis or liver cirrhosis, liver disease history on her. So after her first visit and the initial labs were done, we went ahead and did a core antibody, e-antigen, and a DNA. Also checked her for hepatitis C and hepatitis A. HIV is done in the initial labs, and those results are all there. And so those are the results. And then interestingly for me, I was thinking, oh, she must have been a mother to child transmission at birth, since she didn't receive HBV. And it wasn't until we did the IgM that I thought, oh, maybe she got this from the partner. I'm curious about what your thoughts are about this. This is what we have. So it's hard to know. And that was done later on. Initially, the core was, the other thing that was interesting, that the core was non-reactive as well. Initially, 2 weeks after the surface antigen came back positive. So the core was non-reactive, the e-antigen was positive, and she had that DNA count. And then a month later, we did the IgM, which was reactive, and then the core was now reactive.
What made you think to do the core IgM a month later?
The core IgM. It was with a consultation actually, because it was like, well, it was so curious. And that took a special lab, because all our labs are generally reported a total core, IgM, IgG, and not broken down.
So what did it occur to somebody in the back of their mind that this could be an acute, like a more recent acquisition of the infection?
Well,
later,
I guess it did, because that's why we ordered the core. I mean, the IgM, and so then that took 2 lab tries to get. Our lab wasn't used to doing IgMs, and so once that came back reactive,
right,
that sort of changed the scenario in my mind of what was going on.
Yeah.
And then for her, I was all set to, started talking to her early about the possibility that you know, perhaps she might need to take some medicine because she was already 5 log. And I was thinking, not really knowing what was going to happen with this virus. Was it going to go up during the pregnancy or not, that she might need tenofovir. And then when I did the labs for her and she came back DNA undetectable, I was really blown out with that. And she was delighted, and E antigen was now negative. So I just thought this was a really interesting case. I never seen anything like this before. Mostly it seems like people don't come in with, usually in our situation, when they come in from Micronesia, we don't have any immunization record. We don't have anything, basically, and they don't generally know their status, and the infections are usually from birth, is what the labs seem to indicate.
Right.
So
So I think this is a very interesting case for a lot of different reasons that you've kind of highlighted. One, you know, core IgM is not what we would be, you know, thinking of kind of part of our standard screen for women who are pregnant. But it should be considered. I think that one of the teachable moments here in this case should be considered in somebody who has, you know, again, potential factors to have acquired this more recently. You've seen probably in the news or through kind of these health reports through our local public health agencies that we're seeing just such a dramatic rise in the number of STIs. And remember, hepatitis B is a sexually transmitted infection. And the good news is that most adults who acquire this virus will go on to clear it. And so I think a couple of things here, the partner not being involved, so not being able to really confidently know what the status of that partner is and what risk behaviors the partner's engaging in that might influence this woman's risk, kind of puts her into a higher risk category. It's not like the clear greater than or equal to 2, you know, sexual partners within a 6-month history. This woman hopefully should also get screened for other STIs. We've seen such a dramatic rise in the number of cases of syphilis, congenital syphilis, and other sexually transmitted diseases such as chlamydia and gonorrhea. That it's actually been very alarming that, you know, I actually went to a meeting with some of the folks at our state Department of Health here, and it's just alarming the number that we're now seeing congenital syphilis come back, which, you know, we can lead to stillbirths and poor outcomes in babies and moms who get syphilis long term. So yes, so thinking about you're screening the right women for core IgM. Now, even if you didn't screen this woman for core IgM and she stayed engaged, the good news is that just by doing your additional testing, you would have figured out kind of what was going on, right? And what I mean by that is that her DNA, as you just mentioned, went from, you know, 5 logs to undetectable, right? So that would have probably made you think, oh, what's going on with this viral level, this viral load? One thing I don't see here, did she clear her surface antigen?
I didn't recheck that.
Okay.
We'll do that. That was
Yeah, at some point, she's probably going to clear that as well. Chances are, especially now that her DNA is not detected and her E antigen is now negative. So she's probably in that phase, and it's not going to really necessarily influence things because in terms of her delivery, right? Because she's 30 some weeks now, right?
She's
38.
32, 34 weeks now. When is she due? November 30th is her due date.
Okay, November 30th. Okay, so she's around, yeah, so she still has a few more weeks to go.
Okay.
You could check her surface antigen.
Okay.
Even if she's surface antigen, if she's surface antigen positive, right, and she's E antigen negative now, and you want to make sure she remains this way, right? So sometimes we'll see kind of the viral load go up and down, seesaw, until we're sure that it's cleared. Although most people, by the time they get to undetectable, it stays undetectable from this acute phase. So you're going to still want to monitor the DNA, and I would probably just check the E antibody to see if she forms E antibody, and the surface antigen. Now, let's say her surface antigen still stays positive. She's E antigen negative, and she's DNA undetectable. You're not going to recommend any antiviral therapy for her But the baby, even if you're e antigen negative, remember, independent of the viral load, there's still theoretically a small risk for potential transmission. So the question is, because she's still surface antigen positive, you're still going to offer or recommend immunoprophylaxis,
Okay.
although it's going to be pretty low risk. I'd say pretty substantially low risk, but not zero. So to get it as close to zero as possible, you can still offer immunoprophylaxis to the infant at birth.
Okay.
Okay. Now, if the surface antigen goes to negative, and that's like right at the time of delivery, then you could treat her like a surface antigen negative person. And then the baby does not need to get immunoprophylaxis. Okay.
Okay.
The baby's still recommended, like all babies since 1991, to get a Hep B vaccine, but they can just get it on their standard schedule. Okay, they started a newborn and then they get it over six months.
Okay.
So that's the only kind of thing I would keep in mind. So double check the surface antigen status, because that's still going to influence what happens in terms of immunoprophylaxis recommendation for the infant. And then just really be confident that she's cleared the virus. You can check the E antibody as well.
Okay.
But very interesting case. It just kind of highlights to be assessing risk to me. This is assessing risk in these women. And you would have seen it even if you didn't check the core IgM, because the DNA, right, went to undetected, and that would have made you think, oh, what's going on? That her DNA level went from 120,000 down to undetectable, and the more likely thing is going to be that she's an acute, infection if it stays undetectable. Even if I never had that core IgM reactive, because remember that video that we showed that Dr. Dasu shared with us, that those serology tests are not going to stay positive indefinitely. That IgM is only going to be positive during a window of time. And sometimes that window of time doesn't match up with when they're in the office getting blood work done, or that we're thinking about doing the blood work. And so even if that IgM was never checked or it was unreactive by the time we checked it, really the most logical explanation for somebody to go from DNA, this high to undetectable and stay undetectable would have been, I would have presumed this to have been an acute case of Hep B infection.
Okay.
Yeah. Just because all of the rest of the pattern fits with it, clearing the E antigen so quickly and then the DNA going to undetectable.
Okay.
Yeah. So just keep that in mind. Even if you didn't check the IgM, you probably would have put it together in that way.
I think this is the first time I've seen, or at least recognized, an acute infection in pregnancy. I think most of the patients that we've had have been chronic from birth.
Yeah.
It was like, oh my God, what's going on? And that it cleared in 2 months. It was like a revelation. Everybody was celebrating. The family was happy. And
Yeah.
I was like, that's just amazing, her immune system, especially during pregnancy.
Yeah, I think it just really highlights that we're still seeing it sexually transmitted.
Yes.
It's actually been on the rise in terms of the number of cases of Hep B reported to the local health department since 2013. We've seen this rise along with Hep C. There have been a lot of discussion about parallels to the opioid epidemic, shared routes of transmission, and then just higher rates. We're also seeing a lot more men who have sex with men with increased without protection because of the U equals U issues. So if you're undetectable for your HIV, hopefully you're also getting prophylaxis for your Hep B because you're on treatment for your HIV. So I think a lot of factors are playing into why we're seeing higher rates of Hep B infection today than we did 4 or 5 years ago. And even in somebody who you would have thought this was all chronic infection from mother to child transmission, may not fit that bill. So you just need to really assess risk always.
Mm-hmm.
All right. Any other questions about this case? So getting prenatal vitamins, we talked about the serologies and likely new infection, yes. What follow-up after delivery? So I would definitely follow that viral load for at least a total of 6 months to make sure that they've cleared. And also, if they remain surface antigen positive, that's somebody I would still periodically follow every at least 6 months to see what happens to the DNA level long term.
Okay.
Okay, so, and then if they're surface antigen positive at the time of birth, yes, immunoprophylaxis for the baby. And I would say postpartum contraception is fine, even though they say that there's a potential for hepatotoxicity. As long as you're monitoring the liver tests, we usually say it's fine, even in somebody with known hepatitis B or liver disease.
And would you monitor the liver function in her in particular? Well, I guess we're monitoring it anyways.
You're monitoring it anyways, exactly.
Anyways,
Yeah.
once a year at this point, like once it's been stable every 6 months for a year, maybe once a year.
Yeah, I think that would be fine. And I would be curious just to make sure you follow this person until their surface antigen clears at a minimum. Yeah. And then for usually 6 months to a year after that. All right. I know, Rachel, you've posted the link. Just a couple of comments for those who can stay with us. I had a patient who was breastfeeding her 5-month-old child. Her Hep B DNA was 6 million copies, so very high. The provider told her to stop breastfeeding. She had chronic Hep B. So there actually is no recommendation by the CDC and others based on data that your risk of transmitting this virus is higher through breastfeeding. The exceptions to that is if you have very obviously cracked nipples that are bleeding consistent with severe mastitis and or actually overt bloody discharge in the breast milk. Does that answer your question, Dilanora?
What about the patient herself? Since she has a high viral load, doesn't she need to be on medication?
Yeah, so this is somebody now, then you're just going to evaluate that patient to see if they meet indications for Hep B treatment on her own, independent of the baby, right? So the baby definitely should have received immunoprophylaxis, should finish the vaccine series, and now you're going to do your assessment to see if she in that early phase where she's e antigen positive and the DNA level's high, but we don't think she needs antiviral therapy because her ALT is normal, or is she in a later phase? And so the take-home point here is that typically there's no rush to say that the person has to be started on antiviral therapy in this breastfeeding phase. But the most important thing is that this person needs to be followed long-term and still be counseled if she meets criteria for Hep B treatment independent of her being postpartum or being pregnant.
And other criteria for treatment will be her ALT test as well as fibrosis score, right?
Yeah, so you're going to want to see, like, for example, the things that I would look for is the ALT raised, right? Go back to the algorithms that we went through in the talk last week.
Okay.
Certainly if she's got stage 2 fibrosis or higher, a first-degree relative with liver cancer, any of these things might lower my threshold to talk about antiviral therapy sooner rather than later on her.
Okay, thank you.
Yeah. All right. I think